Hello, everyone, and welcome to tonight's presentation called Stemming the Tide on the Opioid Epidemic. We're very excited to have you here. Glad you could make it. We have people tuning in from literally all over the world. So while we wait for everyone to trickle in, if you want to take a moment to say hi in the comments, let us know where you're dialing in from, as it were, and maybe one or two things you're looking forward to learning tonight. Like I said, really exciting presentation. We're going to get right into it. But before we do, just a couple of quick announcements. First, I want to thank our sponsor. Tonight's sponsor is Young Surgical. Young Surgical, if you're not familiar with them, they're a distribution partner for your practice. They supply critical items from injectables and infection control to biomaterials. And they chose to support tonight's topic because their team understands the shift in pain management that's going on right now. They actively stock all injectables and work tirelessly to find non-opioid alternatives to help stem the tide and reduce patients' reliance in our practices. So, to learn more about some of the products you'll be hearing about tonight, as well as many others, please visit youngsurgicalsolutions.com. And once again, I want to thank them for making tonight's presentation possible and making tonight's event free for you. You are going to be receiving one PACE CE credit for your participation tonight. So I want to make sure I explain very clearly how you'll receive that CE credit. So about an hour after the presentation is over, I am going to send you an email, and that email is going to have a link both to the replay, so you can rewatch this presentation, or if you're not able to make it all the way through to the end, that's fine. You can rewatch it then. But also in the portal that it's going to link to, you'll be able to take a short quiz. It's a knowledge assessment, which is a requirement to receive your CE, followed by a really quick survey just to let us know how we did on this presentation. And then we will email you that certificate of continuing education credit. So it's really important that if you don't see this email from, and once again, from Spark Study Club, from me specifically, within about an hour or so after tonight's presentation, you check your junk folder because 9 times out of 10, if it's not in your inbox, it's there. But if you have any questions along the way, if you don't get that email or if you just can't seem to navigate or find how to get the CE, it's fine. Just email us at support@sparkstudyclub.com. We'll put that email in the chat so you have it. It will also be in all of the emails. It's been in just about every email correspondence you've received leading up to tonight's event as well. So we're always here to help you. We want to make sure you have an easy, smooth process to get your CE, and also want to make sure that you learn and absorb all this material because it's going to be very, very helpful. Okay, so I've been talking long enough. Let's get into it. I want to introduce tonight's speaker. It is Dr. Mark Donaldson. We're happy to welcome him back again. He is a clinical professor at the University of Montana, clinical associate professor at Oregon Health and Sciences University, and affiliate faculty in dentistry at UBC. He serves on the editorial board for the Journal of the American Dental Association and is the 2016 recipient of the Academy of General Dentistry's Dr. Thaddeus Wecklew Award. He's lectured internationally to both dental and medical practitioners, focusing on dental pharmacology and therapeutics. He's a great speaker, and we're just really happy to have him back. You're in for a treat tonight. So it is my pleasure to welcome you back, Dr. Mark Donaldson.
Well, thank you very much for that very kind introduction. Hi, everybody. My name is Dr. Mark Donaldson, and I'm excited to spend almost the next 1 hour with you talking about stemming the tide on the opioid epidemic. Certainly, there are new non-opioid strategies out there, so we'll be talking a little bit about those, and then giving you the latest and greatest in regards to pain management guidelines. Well, thank you very much for that very kind introduction. Hi, everybody. My name is Dr. Mark Donaldson, and I'm excited to spend almost the next 1 hour with you talking about stemming the tide on the opioid epidemic. Certainly, there are new non-opioid strategies out there, so we'll be talking a little bit about those, and then giving you the latest and greatest in regards to pain management guidelines, because yes, there are some brand new guidelines out there, and we want to make sure you have the most up-to-date information on appropriate analgesic prescribing, especially for postoperative dental pain. Now, I don't have any particular disclosures, but it is important that I read out the fact that I have received an honorarium from Young Surgical for this presentation. I have no financial interests that would create a conflict of interest or restrict my independent judgment with regard to the content of this course. Now, as you can see in the bottom right, this is accredited continuing education through the Academy of General Dentistry and their PACE accreditation. And because of that, we in fact do have learning objectives that you can see here. I won't read through them all, but they are contained in your handout. Now, hopefully everybody has accessed the handout. It's important because, as you can see from this little number that's dropped in, all of the words on all of my slides are in fact in the handout. So you should just have to sit back, relax, and hopefully enjoy the show. Really shouldn't have to take any notes. And of course, we will always leave time at the end for questions and answers. All right, with that, I'm really looking forward to jumping into this with you. So first off, I take a lot of continuing education similar to everybody out there. And sometimes I wonder, why is this course important to me? Why is it important to you? What drew you in to the topic at hand? And of course, this is a very, very important topic. You can see that there has been a dramatic increase in overdose deaths because we've had this opioid epidemic in this country now for 25 years. In fact, it's hard to believe. This is a quote back in 2011 that says the number of overdose deaths from painkillers more than tripled over a decade, a trend that a U.S. health official called an epidemic. So even though this epidemic has been with us since 1999, and why can I put such a fine point on that particular date? Well, that was the year that the Institute of Medicine released their very important publication, To Err is Human, where we essentially discovered that many of our patients, our loved ones, were dying in hospital in pain. And that the new mandate was to treat pain as the fifth vital sign and really to do a better job of managing patients' pain. This just happened to come out at the same time that oxycodone was released by Purdue Frederick onto the U.S. market. And of course, with the instruction by the American Medical Association, the Institute of Medicine, and others to help manage patients' pain, we started to see an over-prescribing of opioids. And unfortunately, it's been very hard to get that pendulum to swing in the other direction. And here we find ourselves 25 years later with this opioid epidemic. Now, while this one quote may be the first one in the literature to describe the opioid situation as an epidemic in the United States, it has been repeated. Here you see again in 2017, another White House official declared the opioid epidemic a national public health emergency. Nobody has seen anything like what is going on now. So it continues to be a problem, and we've recognized that for several decades. In fact, even more recently, you can see this release that just came out. The fourth wave of opioid epidemic crashes ashore, propelled by fentanyl and methamphetamine. So while we continue to try to improve our overall prescribing and hopefully turn the Queen Mary in regards to this opioid epidemic in our country, the challenge is that different, newer, in fact, some more potent molecules continue to come to our shores and continue to drive this epidemic. Now, is it only the United States? Well, while we do pride ourselves in being number one in a lot of things, this is not one that I think we have a lot of pride in. But this is not necessarily a U.S. Alone issue. In fact, it's more of a North American phenomenon. You can see here that the opioid deaths in Canada have also been increasing. In fact, this quote, the number of pharmaceutical opioid-related deaths exceeds the number of deaths from motor vehicle accidents involving alcohol in British Columbia. So, in fact, the United States is number one, Canada is number two, and if you were to guess number three, you would probably be wrong, because number three is so far down the list that most people probably wouldn't guess that it's Germany. But the fact of the matter is that Germany and all other countries, in regards to the challenges they face with opioid-related harm, is really much lower than where we are in North America. This really is a North American phenomenon, and we do tend, at least culturally, to be a pill-popping society. So let's talk a little bit more specifically now about the opioid crisis and the role of dentistry. Now, why is any of this important to us? Again, getting back to my very first slide. Well, dentists follow primary care physicians as the second leading prescriber of immediate release opioids. And as such, dentists have been identified as having an important role in opioid abuse prevention efforts. And you can, of course, see the citations at the bottom that reference this, all evidence-based medicine, evidence-based dentistry. And so if we are part of the problem, we need to be part of the solution. And that really is the directive that has been coming down from many of the regulators as well as academic bodies, hoping to encourage us to think about appropriate prescribing for postoperative dental pain in particular. In fact, this opioid epidemic has had such an impact on dentistry and dental prescribers that you can see that our journal, the Journal of the American Dental Association, had 3 cover stories in 1 year on the opioid epidemic and the role dentists can play in helping mitigate this tragedy. How are some of the regulatory bodies getting involved? Well, at a state level, you can see this is just one example of a state board rule. So don't forget that state boards make the rules. They are the ones that grant licensure. So if you don't follow the rules, you can't be licensed. You can't practice in that state. And so for the first time in a long time, the state boards are actually requiring very specifically education in order to retain your licensure around about opioid prescribing and appropriate postoperative pain management. This is just one example of a state that requires prescribers, dental prescribers in that state, take at least 3 hours of education on this particular topic. At the federal level, hopefully everybody listening today has heard of the MATE Act. The MATE Act became a law, and essentially what it now requires is that between June 27th, 2023 and June 26th, 2026, so there's a 3-year time period there, that all dental prescribers who want to retain their DEA license must complete a one-time 8-hour education round about the appropriate pharmacological management of postoperative dental pain. This was a very important act that was first introduced by Massachusetts Congresswoman Lori Trahan back in 2019. You can see the Medication Access and Training Expansion Act. And essentially what the regulators had done is introduced what I've already introduced to you, and that is that we have had an opioid epidemic on our shores since 1999. And by 2019, so after 20 years, to continue to face this opioid epidemic without much change, the regulators said, all right, we have given you folks in healthcare enough time to try to correct this. You haven't been able to do it. So we're going to step in and require everybody that has a DEA license take this 8-hour mandatory education. And if you don't, you will not be able to renew your DEA license. So that's the 3-year gap that we're talking about. We're just over 1.5 years into that. So if you haven't received that training, you need to get it before your DEA license expires. And you can see here that it's a comprehensive curriculum that includes at least 8 hours of training on the safe pharmacological management of dental pain. All right, so again, why is any of this important? Well, if there was one small soundbite, right, one small factoid, a piece of trivia that I carry around with me, it's the fact that 1 in 17 people started on an opioid will become addicted. And, this is an incredible statistic. And I don't think many of us really appreciated this back in 1999 when we were told to treat pain as the 5th vital sign and make sure that we appropriately manage our patients' pain and keep them comfortable. And if that included the use of narcotics, opioid-based analgesics, then so be it. If we had known then what we know now, I think that we probably would have developed some better strategies. The risk of substance use disorder and bad outcomes associated with substance use is actually highest in teenagers. Now, this should not be a surprise to many people, as we've known for a long time that the plasticity of the brain is not fully formed until about the age of 25. And so the earlier that individuals are exposed to opioids, or other addictive substances, the greater the chance that they will go on to develop substance use disorders, addiction issues, as well as other bad outcomes. And so we do really want to focus on this most important population. Some of the common risk factors for teen drug abuse include a family history of substance abuse, mental or behavioral health conditions such as depression, anxiety, ADHD, which hopefully you know is attention deficit or hyperactive disorder, impulsive or risk-taking behavior, which unfortunately seems to define a lot of teenagers, at least in my experience, a history of traumatic events such as experiencing a car accident or being a victim of abuse, and then finally low self-esteem and feelings of social rejection. So these are the common risk factors for teen drug abuse that we most typically see. Again, work done by the Center for Disease Control, published a number of years ago. And the negative consequences or the downstream effects that we are trying to avoid, of course, in this critical population is overall drug dependence, poor judgment, increased and unprotected sexual activity, mental health disorders, impaired driving, changes in school performance. All of these tend to be signs of potential drug abuse in teens and young adults. And we want to avoid these negative consequences if at all possible. All right, another regulatory example from the state level, and this one really surprised me. For the very first time in my memory, here you get a regulatory body, a dental board, actually writing in the rules that the dentist shall consider prescribing non-opioid analgesics as the first line of pain control. So, typically board rules and regulations are a little bit generic, maybe a little bit open as far as specificity. But because of this opioid epidemic, you can see that many state boards, and here's just one regulatory example, are actually telling dentists, if you want to be licensed to practice dentistry in our state, you need to think about non-opioid analgesics as the first line of pain management in your patients. Interesting that we've actually got down to that level now. So when they talk about non-opioid analgesics, on page 2, you should have this list, which are the non-steroidal anti-inflammatory drugs. So starting with acetaminophen, we also know that as Tylenol, and listing off a number of other non-steroidal anti-inflammatory drugs by both generic name and then their one or multiple brand names. Now, one of the teaching points here is, of course, that patients do not speak our language. And so if you are going to be prescribing maximum recommended daily doses of ibuprofen, you need to do a little bit of counter detailing, which is the patient needs to take your prescription as prescribed and not go home and help them to some other analgesics they may have at home. You oftentimes can have patients that will say, okay, doctor, I will take, the maximum recommended daily dose of ibuprofen that you suggest, but I know that Advil or Motrin or Nuprin really works for me, so I'm going to take that as well. And you can see very quickly our patients can get into an unintended overdose situation because they do not always distinguish between the generic and the different brand names for the same or similar chemicals. Now, below the dark blue line in the middle of the screen really are those drugs that we want to avoid. So historically, we've had a number of narcotics that, again, we've been almost encouraged to consider using for patients in pain. But as we're about to find out, there are new non-opioid options available out there. And based on current medical evidence, they really should not be used, these narcotic-containing agents, as first-line therapy. Certainly not in mild, certainly not in moderate, potentially in severe pain, but again, only for a limited period of time, and we'll dive further into that as we go along. Now, for better or for worse, there is a non-pharma-sponsored group called the Beers Group, and every year what they do is they take a look at all of the evidence to date on certain medications, and when they believe that the safety no longer outweighs the efficacy of those drugs, they make the suggestion to the Food and Drug Administration in this country to consider removing those drugs from the American Pharmacopoeia. And that happened with Darvon, also known as propoxyphene, or 642s or 692s. You cannot prescribe, in fact, you cannot get those drugs in the United States anymore because the safety no longer outweighs the efficacy. Don't be surprised if in the next few years the Beers Group makes similar suggestions to the FDA for drugs like pentazocine, meperidine, also known as Demerol. And so from, let's just say, another tact as we try to abate the opioid epidemic, we do have additional regulatory bodies that are actually removing these opioid-containing analgesics from our list of options to treat patients with anyway. So what am I really trying to tell you? That nobody likes to be told what to do. So in advance of being told what to do, in advance of being forced to do something different, make the change now, because really the best evidence to date certainly demonstrates that those drugs above the dark blue line really should be our first lines of treatment for postoperative dental pain, and we really should avoid, in almost all cases, the drugs below that dark blue line. So the most ubiquitous of all analgesics, of course, is acetaminophen. It's certainly comparable to aspirin, also known as ASA or acetylsalicylic acid, as well as many of our non-steroidal anti-inflammatory drugs, those NSAIDs, in its analgesic and anti-fever activity. But the problem with acetaminophen is it doesn't have a lot of anti-inflammatory effects. And as you'll probably remember, pain secondary to dentistry is typically due to inflammation. For that reason, acetaminophen is only going to make up 1/2 of this most important recipe that we are going to build towards. And what you want to do is couple maximum recommended daily doses of acetaminophen with maximum recommended daily doses of a non-steroidal anti-inflammatory drug, something like ibuprofen. That combination really is considered to be first-line therapy for postoperative dental pain. And we'll see examples of this as we go along. So we like acetaminophen, very, very safe drug. It's got minimal antiplatelet effects, meaning that if you go below the gum line and cause bleeding, it doesn't cause that hypoprothrombonemia effect or increased bleeding or decreased wound healing postoperatively like our non-steroidal anti-inflammatory drugs. So it's an excellent medication. And in general, its effects on the gastric mucosa certainly tend to be less than our traditional non-steroidal anti-inflammatory drugs. Now, a regular strength acetaminophen is 325 milligrams. An extra strength Tylenol or acetaminophen is 500 milligrams. And so you can see the usual dosing is anywhere from 325 to 1,000 milligrams 3 or 4 times a day. We can adjust based on where we feel a patient's level of pain is, but just know that the one true guardrail as of today is that in an otherwise healthy adult, we should not exceed 4,000 milligrams of acetaminophen from all sources. Now, at first blush, 4,000 milligrams seems like a very high number, but if you think about it, 2 extra strength Tylenol, they're 500 milligrams each, so that would be 1,000 milligrams. If you give 2 extra strength Tylenol every 6 hours, that gets you to that maximum. So 2 teaching points here. The maximum recommended daily dose in an otherwise healthy adult is 4,000 milligrams, which is what we are going to be prescribing our patients, 2 extra strength Tylenol every 6 hours. But it is an important guardrail that we do not want to pass. And certainly, again, with that idea of counter-detailing our patients, if we tell them to take maximum recommended daily dose of acetaminophen, we do not want them to help themselves from other sources that contain acetaminophen or any other Tylenol product, because, of course, they can very quickly get into an unintended overdose situation. Patients at risk of having some type of liver disease or hepatotoxicity, in other words, those patients with a history of hepatitis or are chronic alcoholics, we would definitely want to reduce that guardrail, that maximum recommended daily dose of acetaminophen, to half. We don't want them to exceed 2,000 milligrams in a 24-hour period. So acetaminophen is, in fact, a very powerful analgesic. Please do not get lulled into a false sense of security that just because it's available, OTC, over the counter without a prescription, that it's not necessarily a powerful analgesic. And certainly in combination with a non-steroidal anti-inflammatory drug, that really is that perfect recipe that we're building towards. Now, there has been some recent information in the news about acetaminophen. And first, I just want to clear up any misunderstandings. Acetaminophen has been around for a very long time, over 70 years now. It continues, even today, continues to be the drug of choice for children with fevers and pregnant and lactating women experiencing mild pain, and it continues to be endorsed by the American Dental Association. So despite everything that you may hear and certain new, in quotation mark, warnings round about the safety of acetaminophen, please know that some of the very latest information that's out there has actually not been able to show a causal relationship between acetaminophen and the potential for neurodevelopmental disorders in the developing fetus. Acetaminophen should remain the drug of choice for fever and pain during pregnancy. You can see two recent publications round about the safety of acetaminophen. Our most important take-home is in this critical population, essentially meaning our pregnant females. It's important if we can try to avoid introducing any chemical during that very critical 9-month period. But if we had to alleviate pain, acetaminophen is the safest in pregnancy, and it's always going to be the lowest effective dose for the shortest period of time. All right. Now, while I have said a couple times that in an otherwise healthy individual, the current maximum recommended daily dose of acetaminophen from all sources is 4,000 milligrams, some people may have noticed that on recent packaging, if you have bought extra strength Tylenol, Johnson & Johnson is actually recommending 3,000 milligrams a day. Now, this is really curious. I'm not sure how many people have thought, why would a for-profit pharmaceutical company, without being regulated to do so, voluntarily change the label on their product, recommending that consumers take 25% less. Of course, I think the obvious answer here is that they know that their product can be dangerous. And in fact, while the current recommended daily dose of acetaminophen is 4,000 milligrams from all sources in an otherwise healthy adult, probably 3,000 milligrams is even safer. And so don't be surprised if we do see labeling changes, or don't be surprised if the FDA does make a suggestion in the near future of lowering that maximum recommended daily dose from 4,000 milligrams to 3,000 milligrams, especially since Johnson & Johnson have already jumped ahead and done that on their labeling. Now, this is an old slide, and the reason I want to introduce it is very important. First of all, what this represents is a number of shotgun preparations. Now, shotgun preparations are drugs that have more than one active ingredient. So other than the first two, which is Tylenol, regular strength, 325 milligrams of acetaminophen per tablet, or an extra strength tablet, which contains 500 milligrams of acetaminophen, you can see that in these shotgun preparations, there's actually quite a bit of acetaminophen in addition to some type of narcotic. And so, again, the teaching point is if you see any of your favorites here, Vicodin, Lortab, Lorcet, please recognize that these should no longer be considered the drugs of choice for postoperative dental pain. And the reason that I have very carefully stated a number of times that the maximum recommended daily dose of acetaminophen from all sources should not exceed 4,000 milligrams is because acetaminophen is not only available in Tylenol products, but it's also available in a lot of these shotgun preparations. Once again, and now for the third time, this is where our counter detailing comes in. If you are going to be recommending maximum recommended doses of Tylenol in your patients for postoperative dental pain, it means the patient does not go home and take that prescription and then augments it with some Lortab, Lorcet, Percocet that they might have lying around from an old knee operation, because there's a lot of acetaminophen in those products too. All right, so I started off saying this is an old slide, and the reason it's old is because there is a group known as the FDA Analgesic Advisory Committee, a non-pharma sponsored group of experts in this area that take a look at all of the evidence to date and, similar to the Beers Group, make recommendations to the Food and Drug Administration to improve the overall safety of medications here in the United States. And one of the recommendations that they made a while back was to limit the amount of acetaminophen in combination products. So if I go back to this old slide, You can see that everything below those two red lines, because remember, Darvocet, propoxyphene is no longer available. Where we used to, past tense, where we used to have 500 or even 750 milligrams of acetaminophen in our Vicodin or Vicodin ES products, I'm going to change the slide. All of these numbers are now 325 milligrams or less. So this was a first step in the right direction to try to minimize the overall exposure of the general population to acetaminophen found in shotgun preparations. But in all honesty, this was not the only recommendation that the FDA Analgesic Advisory Committee made to the FDA. In fact, here is the list. And one I want you to pay the most attention to is the one that I've circled in red and put a little black arrow next to, because this says eliminate prescription combination products. In other words, get rid of those shotgun preparations that contain an opioid and an acetaminophen component. And that was also approved by the FDA. So what's the teaching point here? Well, again, if you have historically thought about using these shotgun preparations for postoperative dental pain, ahead of being regulated to do so, because these drugs may be going off the market, according to the FDA, you're looking at evidence-based medicine right here. Start to make that change now. These shotgun preparations have really been a challenge and certainly add to the overall burden of the opioid epidemic. All right, so if we're going to be giving maximum recommended daily doses of acetaminophen, we should be coupling that with maximum recommended daily doses of a non-steroidal anti-inflammatory drug, something like ibuprofen as an example. Now again, this is not my opinion. We are driven by medical evidence, and so if you take a look at this recent article in the Journal of the American Dental Association, you can see that the conclusion, and this of course is the highest level of medical evidence, this is a systematic review, taking a look at all of the evidence to date, it was concluded that non-steroidal anti-inflammatory drugs should be considered as the drugs of choice to alleviate or minimize pain of endodontic origin. And in situations where these ibuprofen-like drugs alone are not effective, the combination with acetaminophen is recommended. So you can see again from all of the evidence to date, the best prescription for postoperative dental pain really is the combination of acetaminophen and a non-steroidal anti-inflammatory drug. Now, how do the non-steroidal anti-inflammatory drugs like ibuprofen work? Well, their mechanism of action is actually very simple. We have something called the inflammatory response, and don't forget that pain secondary to dentistry is due to inflammation. The molecules in our bodies that mediate the inflammatory response, that cause pain, inflammation, and fever, are known as prostaglandins. So if we could inhibit prostaglandin synthesis, we would inhibit the inflammatory response. And that's exactly what these non-steroidal anti-inflammatory drugs do. So they inhibit the inflammatory response, they get our patients out of pain, inflammation, and fever, and our patients are much more comfortable. In fact, the perfect prescription that we have been building towards is a very simple mnemonic, 2-4-24, where the 2 stands for 2 drugs, the 4 stands for 4 doses, and the 24 stands for 24 hours. In other words, you should be prescribing these 2 drugs, 4 doses for 24 hours. The 2 drugs you now know as acetaminophen and ibuprofen. We want to give maximum daily doses, so that will be 600 milligrams of ibuprofen 4 times a day. That will be 1,000 milligrams of acetaminophen, also given 4 times a day or every 6 hours. Those 2 drugs together, 4 times a day for 24 hours, really is the perfect prescription. Now, you can see this was first published back in 2010. But it has been recommended not just in general dentistry, as you see here, but by the specialists, Dan Becker and his group out of Anesthesia Progress, and then even more recently by Gordon Christensen and his group. Again, all recommending that the combination of maximum daily doses of ibuprofen and acetaminophen really should be the standard of care. Now, while the mnemonic is nice, 2-4-24 makes it very easy to remember. If you want to extend this for 48, maybe even 72 hours, that's perfectly fine. But our goal is always to keep our patients comfortable And as the local anesthesia wears off, we want our oral analgesics to have kicked in. And so that first 24 hours is certainly the most critical time period. So if patients will commit to you to taking these 2 drugs, 4 doses for 24 hours, that should ensure their overall comfort. But depending on the patient, depending on your operative that was performed, you may decide that patients should go maybe 2 days, maybe even 3 days. But if patients are compliant with this regimen and they still have significant pain despite compliance after 2 or 3 days, they really do need to come back and see you because something else could be going on. Now, I always sort of pause here because this is not new, right? Our patients have taken acetaminophen, our patients have taken ibuprofen. We know the kind of surgery that we do. Is this going to work in all patients all the time? And I know the resounding answer is probably going to be no. So let me help you help your patients. Let me set you up for success. What makes this 2-4-24 work? Well, first of all, compliance. In other words, the drug that works is the one the patient takes. And so if the patient does not take these 2 drugs, 4 doses for 24 hours, it's not going to work. And so we really do need to make sure that our patients understand that compliance, medication adherence is really what's going to keep them comfortable. Meaning that if they have a dose due at 2 in the morning, they need to set their alarm, get up, take the dose, and then go back to bed. We really don't want them missing doses. If they miss doses, then of course that allows for breakthrough pain and a patient will certainly be much less comfortable. So how do we additionally set our patients up for success? Well, how about starting in the office, right? The idea that before the patient even leaves your office, you give them the first dose of both those medications. 600 milligrams of ibuprofen, 1,000 milligrams of acetaminophen. And then if you want to further set your patient up for success, in the bottom picture there, what you see are those medication reminder carriers. Now, there is an organization known as healthcarelogistics.com. Again, I have no affiliation with that organization, but almost every hospital that I have worked for in the United States tends to buy all of their non-drug items from healthcarelogistics.com. Just like you can. So you can go to their website. You could purchase these medication reminders. They make them in any size, color, number of wells as you like. You can have your marketing and advertising information attached to them. And then maybe one day after work, you can go to Costco and get a big bottle of extra strength Tylenol, a big bottle of ibuprofen 200 milligram tablets, and put together these little compliance packages for your patients. So your patients don't have to go from your office to the pharmacy home. You actually give them the medications that they need to keep them comfortable once the local anesthesia wears off. So it's an excellent way to go. It's an excellent way to set your patients up for success. And it certainly helps to enforce, if you will, medication compliance and medication adherence. Now, the second bullet point here is an interesting one, right? Because we all have those special patients, right? Those ones that are always asking for that vitamin V, Vicodin, or the ones that almost tell you what you need to prescribe for their pain. And so in those individuals, you need to have an open and honest conversation. And that open and honest conversation typically goes something like this. You know, John, I know you're a special patient. And historically, every time you come here, I may prescribe Vicodin, Percocet, Lortab for your pain, but I need you to know that we have some excellent new news out there, and our office no longer prescribes opioid-containing analgesics. Instead, what we do is we offer maximum recommended daily dose of acetaminophen. What do you think about that? And of course, John is going to say, Doc, you don't understand. That doesn't work for me. I'm a special patient. Oh, you know, John, I wasn't finished. Not only are we going to give you maximum recommended daily doses of acetaminophen, but I'm going to couple that with maximum recommended daily doses of ibuprofen. Now, I know you've had both of those drugs before, but have you ever taken maximum recommended daily dose of both drugs together every 6 hours for 24, or, because you are a special patient, and I don't do this for everybody, 48 or even 72 hours? And I tell you what, John, if you are compliant, meaning that you take these 2 drugs, 4 doses for 24, 48, even 72 hours, if you're still having significant pain, then we'll have another conversation about trying another methodology with you. It doesn't necessarily have to be a narcotic. Of course, we have other options that we're about to talk about. But you do have to sort of sell it a little bit. These patients that are not so much drug seeking, but just don't feel that these over-the-counter type products work as well in them. Sometimes we just need to be able to get them to understand that we empathize with them. But if they are compliant with these maximum recommended daily doses, they may find some success. But we do need their help in being compliant. Now, one of the last questions that I typically get is, well, what about staggering the doses, Mark? Instead of taking these 2 drugs, 4 doses for 24 hours, what if we gave 1,000 milligrams of acetaminophen now, and then in 3 hours, 600 milligrams of ibuprofen, and then in 3 hours, another 1,000 milligrams of acetaminophen, and so on? Well, I will just tell you that there is no pharmacological reason to do that based on the product's half-life and the way that they work together very synergistically. But sometimes we, again, do have those patients, and we call them clock watchers, and I think you know who those patients are, where they just can't wait 6 hours between doses. They know they're going to be in pain, and so, in those individuals, sure, if you would like to stagger the doses of the drugs, that's perfectly fine. Just know that what makes this work, again, is compliance, and so it certainly is much harder to remember to take one drug every 3 hours versus 2 drugs every 6 hours. But in some cases, that may be a strategy that works. And then the last part that I'm just going to highlight on this, because I've written it here, is pill burden. And the idea here is, in the first graphic, you see these 3 sort of amber-colored tablets. Those are the 200 milligram strength of ibuprofen, which is an over-the-counter OTC product, does not require a prescription, coupled with 2 of the extra strength Tylenol, those 500 milligram round tablets that you see. And when you take that combination, those 2 drugs, 4 doses for 24 hours, that's essentially 20 tablets a day, which seems like a lot. And so there are certain individuals out there that, in order to minimize the overall pill burden on patients, may suggest taking the 600 milligram dose, which is that white oblong tablet of ibuprofen, coupled with the 2 extra strength Tylenol, reducing the total daily pill burden down to 12 units instead of 20. That's fine, but I will tell you that these graphics are to scale. In other words, those 200 milligram amber colored tablets, 3 of them is still a little bit smaller than that one very large prescription strength 600 milligram tablet of ibuprofen. And so from a swallowing perspective, it actually probably is easier to swallow the 200 milligram non-prescription tablets versus the singular, almost like a horse pill, 600 milligram prescription strength. Lastly, I'll just mention that there in fact was a study done at the Oregon Health Sciences University in Portland, Oregon, where they looked at the dissolution rate of these tablets and measured blood levels in patients who took either the singular 600 milligram prescription strength ibuprofen that you see there, the white oblong tablet, versus those that took 3 of the 200 milligram over-the-counter non-prescription strength ibuprofen. And actually what won the day was 3 of the 200 milligram over-the-counter doses. They dissolved faster, and blood levels got up quicker and higher than the individual prescription strength. In fact, there were some patients in whom that very large 600 milligram tablet did not entirely dissolve and in fact passed right through their gastrointestinal tract. So there is some science and reasonability, if you will, to coupling the non-prescription over the strength doses that you see in the first 2 graphics, even though it is 20 units per day, versus going to the prescription strength 600 milligram ibuprofen coupled with the 2 of the extra strength Tylenols, even though it does minimize it to 12 units per day. All right, so everybody out there I know is very ingenious. And based on all of this evidence, most of which is not brand new, are probably wondering, well, why don't we have a combination product? Why has a pharmaceutical company not taken a look at all of this evidence and come up with a combination product? And they did. The unfortunate thing is that they did not contact me because they got the combination wrong. They picked the right drugs, acetaminophen and ibuprofen. You can see this product is known as Advil Dual Action. But the contents of a singular caplet is 250 milligrams of acetaminophen coupled with 125 milligrams of ibuprofen, which means that if you try to get the optimal analgesic dose of ibuprofen, which is 600 milligrams, you will greatly exceed the maximum recommended daily dose of acetaminophen. So it's a great idea, just poor execution, and unfortunately, this doesn't meet our needs. In Canada, not to be outdone, as mentioned, they share this burden of the opioid epidemic, and so a company up in Canada did produce Combogesic. Similarly, they did not contact me, and a singular caplet up there contains 325 milligrams of acetaminophen, and then quite precisely 97.5 milligrams of ibuprofen, meaning that if you try to give the appropriate ibuprofen dose, you will actually end up giving the twice the maximum recommended daily dose of acetaminophen, or 8,000 milligrams. So great ideas, unfortunately, poor execution. But maybe the next generation will bring the correct combination forward. At the end of the day, I mentioned at the top of this presentation that we are driven by current medical evidence. And for the first time in a long time, we now have consonance amongst recent guidelines for postoperative pain management. The Center for Disease Control recently produced clinical practice recommendations, which again emphasize the maximum use of non-pharmacological and non-opioid pharmacological therapies. In other words, acetaminophen and ibuprofen, or Tylenol and Advil, as you see in the graphic. And those recent clinical practice recommendations match up specifically to the dental guidelines, not just the new dental guidelines that came out for kids. So you can see the clinical practice guideline here that was released in 2023, focusing on the American Dental Association's Science and Research Institute findings, along with the Pittsburgh School of Dental Medicine, and the two graphics that they have here, the algorithms for the appropriate management of pain in our young people. This, in fact, aligns very, very nicely with the other updated guidelines that came out just 3 months later, also released in the Journal of the American Dental Association, looking at the current guidelines for the pharmacological management of acute dental pain in adolescents and adults. And coming up with the exact same conclusions that first-line analgesic therapy should really be the combination of acetaminophen and a non-steroidal anti-inflammatory drug. So great news. And while the guidelines stopped short of saying, don't ever use narcotics, in the lower left light green box, you can see that the algorithm at some point does in fact allow for a combination of an opioid, such as hydrocodone or oxycodone with acetaminophen, but that you should not exceed 3 days of therapy. And this is only in patients with severe pain. So in that very limited population, based on all of the additional thought processes that go along with this algorithm, they're not necessarily saying don't ever use, but certainly not as first line, not as second line, maybe not even as third line. But if you did happen to have those patients, there may still be a slight role for opioid-containing analgesics. All right. Now, is that going to work in all patients all the time? Well, as we probably responded, no, not based on the patients I have, Mark, or the kind of surgery that I provide. So let me add a couple additions. And the first is something known as preemptive analgesia. In other words, if you know that you are going to cause pain in your patients, if you know that you are going to elicit the inflammatory response, what about providing the patient with some type of analgesic before you cause the inflammatory response? And it could mitigate that inflammatory response. And that's exactly what we typically will do with a drug called Celebrex or celecoxib. Now, this comes from the orthopedic literature, where in most hospitals, when patients are going for total knee, total hip, or total shoulder arthroplasty, on the way to the OR, the patient is given 400 milligrams of Celebrex. And what studies have shown is that the postoperative analgesic requirement is much greatly reduced. There is a growing body of evidence that suggests the same in dental surgery, that giving Celebrex 30 minutes prior to the dental procedure and mitigating that inflammatory response following the procedure up with the 2,4-24 may in fact be that next generation, that next best, perfect analgesic prescription. So think about the introduction of preemptive analgesia as another tool in your toolkit. That's a non-opioid approach to managing postoperative dental pain. If you still don't think that that will be enough in all patients all the time, certainly we have a long history of considering something like a corticosteroid. And in fact, the most commonly used corticosteroid for postoperative dental pain tends to be dexamethasone. Dexamethasone lasts a long time. It has a very long half-life. And so you can either give it preemptively. It comes as 4 milligram tablets, so 4 to 8 milligrams preemptively with Celebrex. Or you could give it postoperatively, again, 4 to 8 milligrams twice a day for, let's say, up to 48 hours. So that is also another great strategy, and of course, a non-opioid strategy to managing our patients' postoperative pain. But something new in the world of corticosteroids is actually based on this brand new publication, again, a systematic analysis, the highest level of medical evidence, in which these authors looked at all of the evidence to date and found that as a single one-time intraoperative dose of dexamethasone up to 10 milligrams, you get almost 5 days of postoperative analgesia. It also reduces early and late edema, as well as early trismus. So what am I telling you? That the idea of giving the perfect prescription 2,4-24 is excellent, but what if you gave this one-time intraoperative dose of dexamethasone up to 10 milligrams and then followed that with the 2,4-24, so that the new perfect prescription may in fact look more like 1-2-4-24, where that 1 represents a singular dose of dexamethasone anywhere from 4 to 8, certainly not exceeding 10 milligrams as a one-time intraoperative dose. Now, this injection, this submucosal injection of dexamethasone, is given very much similar to an infiltration, and all you have to do is, halfway through the dental appointment, wherever the patient is numb, go ahead and inject that dexamethasone. It is a systemic effect. It doesn't have to be given exactly where you're providing dental surgery at the time. But the fact that it gives up to 5 days of analgesia, especially when coupled with our 2,4-24, really does define the perfect prescription. So having said all that, I promise to kind of end our conversation today with some of the new potential non-opioid strategies that you may be hearing about. Where did we start our conversation today? Well, we started off with the opioid epidemic coming to rise in 1999 and continuing on 25 years later, resulting in a couple passages of acts. The first one we talked about, which was the MATE Act, which may affect you if you're looking to renew your DEA prescription. But it also allowed for the Non-Opioids Prevent Addiction in the Nation Act, or the No Pain Act. And the No Pain Act essentially says that if you are going to be prescribing medications for postoperative pain, certainly in the hospital outpatient or ambulatory surgical center, you need to be considering non-opioid strategies. It's actually a law. And so given that law, there are at least 3 new medications that fall into that non-opioid strategy that many of your medical colleagues as well as dental colleagues are looking at. And those 3 drugs are Exparel, also known as liposomal bupivacaine. We'll talk about that in a minute. Journevax, also known as suzetrigine, and then a natural oral hydrogel known as Ora-Soothe. All right, so the first is Exparel, also known as liposomal bupivacaine, as I mentioned. Being sort of the local anesthetic experts, this would seem to be a product almost specifically designed for dentistry. It's actually not that new. It's been in the US market since 2011, and it was brought to market based on two clinical trials, one in hard tissue, one in soft tissue. Those are bunionectomy and hemorrhoidectomy patients. And based on the clinical trial data, the drug was brought under a new class of therapies known as non-opioid long-acting analgesics. So again, we started off talking about the opioid epidemic. It's been around for a long time. In 2011, Exparel liposomal bupivacaine was specifically brought to market to help address the opioid epidemic, and the FDA, in recognition of this new non-opioid long-acting analgesic, actually gave it its own drug class. So really interesting here. Hospital programs started using it right away in the hopes of reducing postoperative narcotic requirements, and lots of exciting news around Exparel. Now, if I was to kind of break it up into the good news, bad news piece, it does provide up to 96 hours of pain relief. So as a liposomal formulation of bupivacaine, it's your standard bupivacaine, but with this special coating that allows for a slow release of the drug over time. So in these very painful surgeries, bunionectomies and hemorrhoidectomies, intraoperatively the drug was administered, and it provided up to 96 hours of pain relief for these patients. Again, allowing for a decreased requirement in postoperative analgesics. Again, it's injected at the time of surgery, potentially decreasing the need for opioid analgesics. Now, the bad news is a little bit of the fact that if it works for 96 hours, while that's great news, if you happen to pick the wrong patient on the wrong day, or the patient has an untoward reaction, the drug lasts for 96 hours, and without a specific reversal agent, that can be a challenge in managing those patients. So while the 96 hours of pain relief is good news, in certain patients, and I admit it's probably a small population, it could be bad news. It's expensive. There's really no getting around it compared to our typical cartridge of plain bupivacaine, which a box you're probably paying around about $50. A singular ampule, the average wholesale price right now for Exparel is close to $400. That's a consideration, but in certain patients, obviously this could be ideal. Not currently approved for block anesthesia, and one of the concerns from a dental perspective is that it cannot be used around the time that other locals are being used. Now, this is again a growing body of evidence here, but according to the package label, this is something that needs to be sort of vetted out. But as I said, there is certainly a growing body of evidence in support of using Exparel in the dental realm. What happened in medicine since 2011 is a lot of hospitals added liposomal bupivacaine to their formularies, and the clinical trial evidence, which was supposed to be able to demonstrate a decreased overall length of stay in the hospital and a decrease in narcotic requirements postoperatively, didn't necessarily pan out for all patients and all hospitals. And given the price of Exparel, it started to become a little bit of a budget buster. And so there was at least one summary article that came out from anesthesiology. You see that here, that shows liposomal bupivacaine was found not to be different from plain local anesthetics for postoperative pain and all other analgesics and functional outcomes. So medicine is still trying to determine, the best place for liposomal bupivacaine, but that again kind of opens the door for where we're seeing perhaps the greatest opportunity, and that's the utilization of Exparel for postoperative dental pain. Again, from a dental perspective, I think we are all very well aware that getting close to the end of the dental appointment, injecting the patient with a long-acting local anesthetic such as bupivacaine or etidicane certainly delays onset and severity of postoperative pain outcomes while the oral analgesics are taking effect. Lots of data in support of that. And so liposomal bupivacaine or Exparel may actually fit a role here and be an extension of what we already know to be true, and that is perhaps offering an even longer acting formulation of bupivacaine, keeping our patients comfortable, and again decreasing the need for certain post-operative analgesics. So more to come. I think that's the exciting news here with Exparel in dentistry. A brand new class of drugs was just approved in this past year too, and the first one out is known as Journevax or suzetrigine. This is a novel, again, a non-opioid drug for treating moderate to severe pain, especially following painful surgeries. So a unique molecule comes as 50 milligram tablets. Usual dose is 100 milligrams right away, and then 50 milligrams twice a day up to 14 days. Again, as a unique molecule, this is especially useful in painful surgeries, so you can certainly put certain dental procedures into that category. Again, perhaps the challenge is cost, which is anticipated to be about $31 a day. But the bottom line for suzetrigine really is the excitement round about its mechanism of action. So it targets the voltage-gated sodium 1.8 channels, and by inhibiting that, it actually manages to keep our patients, who we would typically assume to have moderate to severe acute pain, much more comfortable. Now, these particular voltage-gated sodium channels are found in the peripheral nervous system. So again, targeting where we are causing pain from a dental perspective. And by blocking that pain signal to the central nervous system, our patients are essentially kept comfortable. So it's really the first FDA-approved non-opioid analgesic in almost 20 years. And so really exciting here from a medical standpoint, and there may be opportunity for this to address some of our concerns, again, as another tool in our toolkit for managing post-operative dental pain. No clinical trial data yet in that realm, but it's something to certainly consider. And again, in contrast to opioids, suzetrigine may have a role in being compliant with that No Pain Act. So lots of good information here, lots of excitement around not just a new drug, but a new mechanism of action. And then finally, I'd be remiss if I didn't mention at least one more tool in your toolkit, and this is more of a natural product. So this is AuraSoothe. AuraSoothe comes in a gel or a rinse. It's made from what we call grass ingredients, and that's not the kind of grass that's outside on your lawn, but it's generally recognized as safe per the FDA. And so the non-toxic ingredients, this all-natural sort of drug-free formulation, is comprised of aloe, xylitol, essential oils of cinnamon, clove, and thyme. The benefits certainly include that when you're using it for mucositis or stomatitis, that it's safe as swallowed. It's safe for all ages, which is a little bit different than the last two products we just reviewed, perhaps being a little less safe in younger populations, or at least not studied so much in those populations. And of course, it has a nice fragrance and taste. Now, why would we use these products in particular? Well, the ingredients in and of themselves have unique actions. Some are antimicrobial, some are antibacterial, but most importantly, they do have anti-inflammatory effects. And as we've stated a number of times now, pain secondary to dentistry is due to inflammation. And so these natural products tend to work perhaps best in conjunction with our prescription medications to provide that level of comfort that we're looking for our patients. The bottom line is that there's a couple formulations. The gel syringe format, which is very good for localized treatment, and perhaps the oral wound dressing in a rinse, the hydrogel oral wound dressing, may be good for other types of patients. But I think the bottom line here is a clear one, and that is another tool in your toolkit, another arrow in your quiver, if you will, is important. So that's actually a great place to sort of bring it all together. You know, why have we been talking about this? Well, dental pain continues to be a challenge. The opioid epidemic continues to be a challenge. But why is this such a challenge, especially today? And it's primarily because of the definition of pain. Pain is whatever the patient says it is. And so if you think about that, we have as many definitions of pain as we do different patients. And so the ability to use the correct medications at the right time for your patients, guided by the guidelines that we've talked about, is certainly very important. But because we really do want to customize our approach to postoperative dental pain, having the ability to reach into that armamentarium and recognize that there are other opportunities above and beyond just the acetaminophen and ibuprofen combination really should help you keep your patients comfortable given the uniqueness of their own definition of pain. All right, so really appreciate everybody's time. I think I'm getting the wave there. Yes, it looks like we do have time for a few questions. So let's dive into the question and answer session. And again, for completeness, you have my email address. Please feel free to reach out anytime, and I try to return all of my emails within 24 hours unless I'm traveling.
Well, thanks, Dr. Donaldson, for just another outstanding presentation. As always, really appreciate it. Great engagement from our audience who has stayed on to the very end. So thank you, everyone, for sticking it out. Obviously, it means we must be doing something right here. So appreciate that. We did get a number of questions coming in. We're not going to have time to answer them all, so we'll follow up with you offline if we don't get to your question tonight. But I do want to start with this one because I think it's very good. First of all, starts with a compliment, which I'll share. Great presentation. Just so many excellent clinical pearls I can begin to introduce as soon as I get back to the office. So thank you again. My question is, for the dexamethasone injection, does it matter how or where we inject?
Great question. And if I wasn't clear, I apologize. But the injection is given as an injection in the mouth, sublingually. As basically you would give an infiltration. The most important thing is to inject wherever the patient is numb. That way they're not going to feel the injection, and you're going to get the benefit of up to 5 days of analgesia. Again, for that intraoperative injection of dexamethasone, up to 10 milligrams. I should also emphasize that while 10 milligrams is the maximum, it's not the target. In fact, most of your colleagues probably use anywhere from 4 to 8 milligrams as that single one-time intraoperative injection of dexamethasone. Great question. Thank you.
Yeah, and I'm going to skip ahead because while you were answering that question, we got a follow-up question. I'll read that to you now. I had a similar question to the previous listener. I think dexamethasone comes in different injectable concentrations. So which one would you recommend?
Yeah, wow, that's somebody that's got a pharmacy background. So you're right. Unfortunately, dexamethasone, the injectable format, does come in at least three different concentrations. So one is the 4 milligram per milliliter, one is the 10 milligram per milliliter, and then the highly concentrated 20 milligram per milliliter. Now, this is an important point because I think as clinicians, when we inject, we're not always thinking about concentration, right? We're typically just thinking about volume. And so, if most of the time you guys are giving a 2 milliliter volume injection, which is essentially how much fluid is in a local anesthetic cartridge. I know it's 1.7 milliliters, but close enough as we say in pharmacy. So you're so used to always giving a 2 milliliter injection. My suggestion for you would be to use the 4 milligram per milliliter concentration of dexamethasone. That way, if you're giving 2 milliliters of that, that's going to be 8 milligrams, and that will be in that target range. Does it mean that you couldn't use the 10 milligram per milliliter? Not at all, but just recognize that in that case, with that higher concentration, you can't give more than 1 milliliter of solution. So a couple teaching points. First is pick the concentration that works best for you. And as I said, I would suggest the 4 milligram per milliliter because up to 2 milliliters means 8 milligrams. And secondly, stick with that. So if you happen to be the person in the office that is not the buyer, and they suddenly see a sale on a higher concentrated dexamethasone, and they buy that, and they don't tell you, if you're always used to giving 2 milliliters every time you use dexamethasone, and suddenly it's interchanged with the higher concentration, then you could be actually above that safe dose. So it doesn't matter to me which concentration you pick, as I would suggest, probably the 4 milligram per milliliter, and stick with that. Certainly don't change concentrations because again, most of us are always focused on the total volume, and we pay, unfortunately, a little less attention to the concentration sometimes. But excellent question.
Perfect. So roll right into the next one. Is there a place online where we can get our MATE, MATE hours if we haven't done the 8 hours of training yet?
Yeah, that's a great question too. So there are a few. If you go to OHSU, that stands for the Oregon Health Sciences University .edu. So ohsu.edu. I do know that they have modules online. I'm only mentioning that because I am affiliated and have put those modules together. There are probably other places as well, but off the top of my head, just because it's so easy to remember and sort of rolls off the tongue, ohsu.edu, and then just search for MATE.
Perfect. Next question. You talked a little bit about pill burden when describing the 2-4-24 recipe. Can you expand on what you meant by that?
Yeah, and I think I may have done that a little bit in the presentation, but again, forgive me if I went too quickly. So when you are using the over-the-counter products, the 200 milligram strength ibuprofen with the 500 milligram extra strength acetaminophen tablets, in total, the 2-4-24 means that your patient's taking about 20 tablets a day, which, to you and I sitting here talking about that right now seems like a lot. And so there is sometimes the concern that in older patients, especially with swallowing difficulties, are they actually able to take that many tablets in a day? One of the ways to mitigate that is instead of using the over-the-counter 200 milligram ibuprofen tablets, is to use just a singular 600 milligram ibuprofen tablet. And the problem, of course, is it's a prescription item, so you would have to be writing a prescription for that. And then if you remember or you go back to look at my slides, they were to scale, and so that 600 milligram prescription strength ibuprofen, even though it's only one tablet, it's a pretty big tablet. In fact, it's almost the same size as swallowing three of the 200 milligram non-prescription tablets. So initially, I think when we look at the pill burden, am I making my patient swallow 20 tablets a day versus 12 tablets a day? I don't think the difference is that great. And then finally, the real take-home message is that that study that was done at the Oregon Health Sciences University, where a dissolution study showed that by taking three of the 200s versus one of the 600s, you actually got blood levels of ibuprofen up higher and faster, and they were seen to actually be much more successful and efficacious versus taking that much larger 600 milligram prescription strength ibuprofen. So I don't think pill burden is really an issue when you dive into it. And in fact, the 20 tablets versus 12 tablets is probably more efficacious based on that OHSU study. But it is a good point, and certainly worth considering. As we've said all along, the drug that works is the one the patient takes. So we want to make sure that we set our patients up for success. And perhaps in that small population that does have swallowing issues, maybe the fewer pills could be better.
Perfect. This next question is a little open-ended, but I think it's a good one. How is Exparel being viewed by our medical colleagues?
Wow, that's somebody that looks like they're kind of diving into my world here. I wouldn't say that physicians in hospitals are thinking that they got sold a bad bill of goods here, but I think that Exparel was very opportunistic. So the company Pacira that brought Exparel to market, actually managed to convince the FDA to approve their drug underneath a brand new drug category. So Exparel was the very first non-opioid long-acting analgesic to be marketed. And, on the backdrop of the opioid epidemic, not even knowing anything about the drug, just knowing that this is at the time the only drug in the non-opioid long-acting analgesic category, all of a sudden meant that if physicians wanted to keep their patients comfortable, but they wanted to use a non-opioid FDA-approved medication, then this was obviously the one. As I mentioned in the presentation, the two sort of primary endpoints in both the bunionectomy and hemorrhoidectomy studies, which again was a decreased use in narcotics postoperatively and a decrease in overall length of stay in the hospital. Those, while the endpoints were reached statistical significance, really didn't reach what we sometimes interpret more as clinical significance. And so because of that and how things have evolved with the utilization of Exparel since it came to market, not really shown to be any more efficacious than plain bupivacaine, and then also noting some of the contraindications that I spoke about. I think it was kind of a good drug attempt. at the time, but as I mentioned, most hospitals that added Exparel to their formularies have either removed it because it's become quite a budget buster, or they have definitely implemented a number of restrictions such that only special populations or certain procedures are allowed to use the drug. But there's always new things coming, so we certainly appreciate the work Pacira and Exparel did. But it really, I think, just opened up the opportunity for better medications to come.
Very good. All right, well, it's getting late, so I think we're going to leave it there. I want to thank our sponsor again, VitaLert. If you're interested in any of the opioid alternatives discussed this evening, you can reach out to them at vitalertkit.com. We'll also put that link in the chat, and we would invite you to go check them out. And always appreciate our sponsors for allowing us to deliver such valuable, important education. Also, as a reminder, you will be getting an email from me in about an hour. Just need to wait for this video to render. And that email will provide you access to this course module where you can watch the course online, but probably more importantly for you, you can receive your CE. You receive your CE by following the instructions. It's very simple. Just take number one, the knowledge assessment, and number two, the survey. And once those are done, you will get an email instantly with your CE verification. As always, please reach out with any questions at all. Our email address is support@sparkstudyclub.com. Or if it's easier, you can just go to our website, sparkstudyclub.com, and hit the contact us button. Dr. Donaldson, thank you again. It's been a pleasure. I always appreciate your time and really, really great content tonight. So thank you.
Thanks, Donovan.